Hi, my name is Dr. Stephen Beldner. I'm practicing in Lenox Hill Hospital in New York. I'm part of the Northwell system, and I'm here to discuss vascular disorders of the upper extremity. Vascular disorders can arise from three different locations to try to simplify this. The pump, which is the heart, which everybody knows pumps ANSEF to the bones. The pipes, which are the arteries, and then my favorite as an orthopedist, the bones, which I refer to as nirvana. The pump, which we discussed, the heart, is again the number one source of thrombi to the upper extremity. And whenever you hear somebody say something twice, it means it's probably going to show up on an exam. So try to remember that. It's usually more proximal, larger occlusions. It can occur in the lower extremity, and it can occur in the brain, strokes, things like that. So it usually doesn't just affect the upper extremity. Causes of this can be atrial fibrillation, or if you have a valvular disease or damage, they can throw thrombi to the rest of the body. If you catch these occlusions within 36 hours, they are amiable to either thrombolytics or embolectomy. As far as workup is concerned, echocardiograms are an excellent way of imaging the heart. You can either see a mural thrombus sometimes, or you can see valvular disorders, which are picked up very easily on echocardiogram. Getting into some of the anatomy when we leave the pump, on the right side of the body, the brachiocephalic artery divides into the right subclavian artery and the right common carotid artery. On the left side, the common carotid artery and the subclavian artery are separate, and the subclavian comes right off of the arch. Moving down the extremity, the subclavian artery ends at the lateral border of the first rib and then continues as the axillary artery. At the end of the lower border of the teres major, the axillary artery becomes the brachial artery, and that continues down to the artery, that continues down to the arm until it reaches a division point. This division point divides the brachial artery into the radial artery and the ulnar artery, which generally occurs distal to the elbow. The radial artery crosses down the forearm between the FCR and brachioradialis. Eventually, it will cross deep to the first dorsal compartment and penetrate the two heads of the first dorsal interossi and the pollicis brevis to make up the bulk of the deep arch on the volar aspect of the palm. The ulnar artery, which is found deep to the FCU and radial to it, will continue down the arm and in the wrist enter the area called Guillen's Canal and will become the bulk of the superficial arch. Now these arches are connected and interconnected between the radial and ulnar artery. So for most people, they can have supply from both vessels, but there are some people who have only supply from one or the other, which can be checked on what's called an Allen's test. In the hand, initially, the common arteries, common digital arteries, are found superficial to the nerve. But when we move distally, the arteries switch position and the nerves become more superficial to the artery. So that when we get to the digital arteries in the finger, the nerve is superficial. But within the palm, the artery is found deep to the nerve. And that's an interesting portion of anatomy, which is sometimes checked or tested on these exams. The ulnar digital arteries are dominant on the radial 3 digits, where the radial digital artery is dominant on the ulnar 2 digits. The anatomy of these arteries is that the endothelium is a thin layer on the inside of the vessel. The flow through that vessel is controlled by the media, which is mostly muscular region, which can contract and relax and control the diameter of the blood vessel. The third layer is the adventitia, and what the adventitia is, it's a fibrous tissue that invests around the vessel, and it sort of acts as sort of like a cushioning and protection of the vessel. Injury to these vessels can occur in three different ways. There can be an extrinsic injury to the artery, an intrinsic injury to the artery, and then damage to the lumen itself. And we're going to break these into these three categories to better understand how the vascular system can be injured as far as the artery is concerned. The most common source of emboli from the upper extremity is from the subclavian artery. It usually is associated with thoracic outlet syndrome, and about 90% of cases have a bony abnormality like a cervical rib. There can also be not only just a stenosis, but sometimes true aneurysm from chronic irritation of the vessel between the rib and the clavicle. Vascular studies are a nice way of evaluating these arteries. When looking at the subclavian artery, it's really important to remember that you need to use femoral access because an axillary access will not give you appropriate visualization of the upper extremity. So whenever you're concerned about this, you should use femoral access to evaluate the subclavian artery so that you don't miss the anatomy. There are other vascular studies which are helpful as well. One of the more commonly used ones is called the DBI, or the Digital Brachial Index. And basically it's a blood pressure taken at the brachial area and a blood pressure taken on the digital vessels in similar fashion. And what you do is you divide the digital blood pressure by the brachial blood pressure to form a ratio. Normally this ratio should be above 0.7. And if you're above 0.7, that usually means there's enough circulation to allow for the digit to survive. If it is below 0.7, then usually there's vascular insufficiency, and either you need to do some type of revascularization or amputation once the tissue dies. This can be misleading in diabetics since their arteries are calcified, and if their arteries are calcified, they're more difficult to compress, which may throw off the study. Traumatic injuries, which can be extrinsic to the system, can occur in two fashions, either blunt or penetrating. With blunt trauma, such as repetitive hitting of the hypothenar region, you can develop what's referred to as a true aneurysm. A true aneurysm contains all three layers, so it has the endothelium, the medium, and the adventitia all intact, but they've been structurally weakened, which allows the vessel to dilate. On a vascular study or angiogram, this can be appreciated since the true aneurysm will be concentric and will be in the center of the vessel. In hypothenar syndrome, which is a true aneurysm, the diagnosis is made by angiogram, but the treatment is based on the DBI as discussed earlier. If it's below 0.7, which is our magic number, there is a vascular insufficiency. And in order to treat that, you must restore the circulation by doing some type of graft. If the graft is above 7 centimeters, though, there has been a higher rate of failure, so that should be kept in mind and be watched very closely post-operatively. If the DBI is above 0.7, then there's no need to do a vascular reconstruction. So a lot of surgeons will just do a resection and something called what's called a Laceration Sympathectomy. By resecting the vessels, you're also resecting the nerves which travel with it, which actually increases the circulation by reducing the sympathetic outflow to the hand, since most of it travels along and with the ulnar artery with a small nerve. Sharp trauma can lead to something called a false aneurysm. Now, a false aneurysm is a lot different than a true aneurysm. It's generally due to a penetrating injury to the vessel. When you look at these, they're missing the endothelial layer, and they are much more common than a true aneurysm. They can be detected again on angiogram, but this time, instead of being concentric, you usually find them lying eccentric on the vessel. So it almost looks like a little egg which is hanging off of the blood vessel. Complete lacerations generally do not cause a problem in the hand since there's a lot of collateral circulation. Partial lacerations can lead to pseudoaneurysm, and they should be repaired. If there's vascular insufficiency or a DBI less than 0.7, again, these need to be either repaired or reconstructed, or else you'll wind up with vascular insufficiency and possible tissue death. Vasospasm is another reason why a blood vessel may be dysfunctioning, and it is intrinsic to the blood vessel, and there's a lot of reasons of why this can occur. The phenomenon is called Raynaud's phenomenon, and it's associated with a vascular insufficiency of the hand. The vessel goes into spasm and restricts its circulation. It starts with a pale white hand, and over time you get some venous stasis, and the finger starts to turn blue. And then finally, as the vascular restriction resolves, the fingers will become hyperemic for a period of time. And this is referred to as Raynaud's phenomenon. Now, Raynaud's phenomenon was described, but Dr. Raynaud wanted to distinguish it between Raynaud's disease and Raynaud's syndromes, and these are separate conditions. Raynaud's disease has no associated conditions. They generally occur in young females, and they run a benign course. And we've all come across these patients. They get pain and discomfort in cold weather. They generally will not go on to lose tissue, and for most people, treatment isn't necessary. In Raynaud's syndrome, this is an associated condition with some type of rheumatologic condition. We see a lot in lupus or in scleroderma. These patients will go on to lose tissue and generally do need treatment, either medical or surgical. Buerger's disease is also another disease of the blood vessel. It's an inflammatory occlusive disease of small and medium vessels. Predominantly, they affect the lower extremity and occur in young smoking males. Once again, the diagnosis can be made by angiogram, and what we see are these little corkscrew vessels which occur more distal than proximal. And we often see collateralization since this is a very chronic condition, and since circulation is lost slowly, the body makes a strong attempt to try to increase the circulation by creating new blood vessels in the hand. The treatment for Buerger's disease is to stop smoking, which reduces vasospasm. Sometimes vascular reconstruction is necessary, and if soft tissue loss occurs, either debridement or amputation. Scleroderma is also another condition associated with Raynaud's phenomenon. There are two types, progressive systemic and limited cutaneous, also referred to as CREST. CREST stands for calcinosis, Raynaud's, esophageal dysfunction, sclerodactyly, and telangiectasias. About 30% are rheumatoid factor positive, and they can have an ANA positive with a nucleolar pattern, which helps diagnose them on exam. They also have their own rheumatologic test as well. Treatments for scleroderma can be either conservative, medicines, biofeedback, obviously stop smoking, since smoking has the highest predictor rate of going on to amputation. Surgical intervention can occur as well. Sympathectomies can increase the circulation and reduce vasospasm. Sometimes fusion is necessary for severe contractures, and if the calcium deposits are symptomatic, excising the calcinosis. This is a case of a scleroderma who's undergoing a sympathectomy, and over here you can appreciate the digital nerve and some of its branches. Here's a very thickened adventitia around the artery, and here we see a little branch of the digital nerve going into the artery, and during this procedure this will be identified under the microscope, electrocauterized and divided to reduce the sympathetic inflow into the blood vessel. Scleroderma can be associated with significant tissue loss, and this is a patient who recently had a digital sympathectomy and had loss prior, which was debrided. And over a period of time, we can see with the improved circulation that the tissue begins to regenerate, and often we can get the skin to regenerate over the end of the finger. Now, obviously, there's been resorption of the distal phalanx, but certainly without the sympathectomy, this would have gone on to amputation. Injection injuries can be seen in drug addicts. Generally, what will happen is that whatever they're injecting sort of clogs up the vessel. Determining the degree of injury, an angiogram would be very helpful. It will allow you to determine what's been clogged off and what's reconstructible. If you can see these before 36 hours, streptokinase or embolectomy can sometimes be performed. After that point, usually you're going to have to go to some other reconstructive procedure. Also remember that these patients are at increased risk for developing compartment syndrome. So if there's any signs or symptoms of compartment syndrome, that should be addressed while you're addressing the vascular insufficiency. Having reviewed the blood vessels, we're now going to move on to the bone. The most two common types of vascular injury to the bone is Kienbock's disease, which is found in the lunate, and Preiser's disease, which is found in the scaphoid. Kienbock's is described by Robert Kienbock in 1910. So there's two presentations to Kienbock's. The first is males between the age of 20 to 40. Sometimes they'll be operating heavy equipment or repetitive trauma. This is usually on their dominant hand, but there is no association with like real serious trauma. The second presentation we see this is females, and this is usually middle-aged females, and the dominant equals the non-dominant prevalence. They generally will present in similar fashion. They have dorsal wrist pain, stiffness, and decreased grip strength. The vascular anatomy has been worked out, and what we find is that about 59% of people have a Y-type vascular pattern within the lunate. 31% have this I-type, and 10% have the X-type. It's been postulated that the I-type is the one which is most likely to go on to develop Kienbock's, since it has a very limited circulation. But obviously this has not been proven. There's a lot of different ideas that are associated with what causes Kienbock's. One of the oldest ones is Holton's theory, and Dr. Holton believed that because of the negative ulnar variance, it created a shear force across the lunate between the radius and the ulna, and that was the reason why Kienbock's occurred. And that was one of the earlier treatments, and what they said was that you could shorten it and level the procedure of the radius so that the radius and lunate were in a reasonable height. And lo and behold, about 80% of people would get improved with this type of treatment. Suge also looked at this, and he found that there was an increase in radial inclination. And he decided that it was the increased radial inclination. So when he did his osteotomies, he would reduce the radial inclination and palmar tilt. And he said that that would improve. And lo and behold, he had 80% success rate. When they did the biomechanical studies for this, what they found was that when they reduced the radial inclination, it actually increased the stress force of the lunate between the radius and ulna. And some doctors came along and decided that by increasing the inclination, that would get rid of it. And lo and behold, their results were about 80%. Eventually, somebody said, well, what happens if we don't change the inclination? And they did what's called a core decompression. They would just go in there and scoop out the cancellous bone of the radius and ulna. And eventually what they found was 80% improved. And they believe it's due to the fact that it increases the circulation to the area and that revascularizes the bone. And that all of the cutting of the bone was unnecessary. Now, the jury's not out on this. People still argue about the reasoning of what causes Kienbock's. But people are, or the trend is that most people are doing less aggressive procedures such as core decompression. The treatment for Kienbock's is determined by its staging. And it usually stages from an early stage with very little damage to eventual arthritis. The X-ray is the least expensive way to pick up Kienbock's, and in a stage 2 arthritis, stage 2 Kienbock's, frequently you can see some sclerosis or changes. The MRI is more sensitive though, and it will pick up Kienbock's or avascular necrosis of the lunate even before an X-ray does. The CAT scan is the best way of determining the stage of it, how much bony damage has been determined. So if the question is, what's the most sensitive, or how can you pick it up the earliest, the answer is going to be the MRI. If you're looking for what's the first mode of assessing, an X-ray is readily available, and that usually will be the answer. And if the question is, how do we stage it, the answer is going to be a CAT scan. Staging goes from stage 1, which is a normal lunate with shape and density on X-ray. You might pick up a linear fracture, and usually you can only see these on MRI. Stage 2 is lunate sclerosis, but you don't see any collapse. Stage 3 has been broken up into 3A and 3B, and this is where things really start to change. In stage 3A, the lunate begins to fragment and collapse, but the carpal height is preserved. In a stage 3B, the scaphoid begins to flex as the scapholunate ligament fails, and the triquetrum begins to extend and migrate. And once it gets to this point, it really limits some of the reconstructive procedures available. Stage 4 is just basically arthritis. The joints are destroyed. Treatment options depends not only on the staging, but on the age of the patient, since children will respond to treatment differently than adults. Non-surgical treatment is usually reserved for stage 1, cast immobilization. It's not tremendously effective in adults, but has been fairly effective in children under the age of 12. As far as surgery is concerned, there's a wide variety of treatments. Surgical treatment in the pediatric population has been found to be effective with just what's called a scaphotrapezoidal pinning. And the idea is that we're trying to unload the lunate by pinning the scaphoid to the trapezoid. Generally, this is done for approximately 3 to 6 months until changes in the lunate start to become normalized. That is only used in children though. As far as adults, stage 1 through 3A are pretty similar. Some people would argue radial osteotomy, either radial shortening to level it, or changing the inclination, either increasing or decreasing as discussed earlier. Core decompression to create a vascular inflow to the area by healing has become much more popular. Revascularization, capitate shortening, lunate replacement have all been discussed. Once we get to 3B, although some people would try these, most people are thinking of either limited fusions or proximal row carpectomies. And with stage 4, either proximal row carpectomies and either wrist fusion if the joint is destroyed enough. As far as looking at these questions, we've discussed a lot of in-training that I hinted to about. Very difficult when you're taking these exams to be able to figure out the level. Try not to overread, try not to underread, and sometimes when they ask you to find X, it's as simple as it is here. Going over some of the questions, this is a 19-year-old man sustaining a laceration to his palm that was repaired primarily in the emergency room department 3 weeks ago. He now reports a tender pulsatile mass in his palm and intermittent tingling and numbness in his ring finger. A clinical photograph of the mass is shown in figure 83. What is the next appropriate step of management? And what we see is a pulsatile mass after a penetrating laceration in the palm. MRI would show this, but it's not going to give you a lot of information. It's sort of clear from the history that this most likely is a pseudo-aneurysm. EMG will tell you a lot about the nerve and the tingling, but we can assume that the tingling is coming from the fact that there's an aneurysm there and pushing on the nerve. So I don't think that that's going to be the most appropriate. intraarterial urokinase infusion, or ethanol embolization. I don't think that those are going to really be very helpful because they're not going to get rid of the pseudoaneurysm, and surgical exploration would make the most sense. Which of the following best describes the anatomic relationship of the digital artery and nerve? Well, they're talking about the digital artery and nerve, so we're in the finger. And as discussed earlier in this lecture, the nerve is going to lie superficial to the artery. So number 3, nerve palmar. Now, if they asked this question again, but they said in the palm, the opposite would be true. In the palm, the common digital arteries are superficial to the nerve. And this is basically an anatomy question that you either know or you don't. Next question. A 38-year-old construction worker with no history of trauma has had a painful swelling and hypothenar impotence of his dominant hand for the past 4 weeks. He also reports numbness of the ulnar 2 digits and cold intolerance. Which of the following study is most useful for diagnosis? CT scan. The clinical history is of a hypothenar hammer syndrome, or a true aneurysm of the ulnar artery. A CT scan would not help in evaluating that. A bone scan, again, is evaluating the bone and not so much the artery, so I don't know how helpful that would be. An arteriogram would give you an excellent resolution of the artery to determine the collateralization and how much circulation. So that sounds good, but I'm still going to read the other 2 questions. Doppler and ultrasound, that could be helpful, but not as helpful as an arteriogram. Electrodiagnostic studies. It will tell us about the nerve, but the nerve is secondary to the aneurysm, so I think the most useful would be the arteriogram. Which of the following is associated with recurrent ulnar artery occlusion after vascular reconstruction for hypothenar hammer syndrome? Preoperative repetitive palmar trauma, well, they almost all have that, so I don't think that would affect the postoperative results. Vein graft above 7 centimeters, oh yeah, we talked about that. For the people who are able to stay awake, I think you guys got it right. Female gender, preoperative cold intolerance, symptoms in the contralateral hand, all would be not tremendously effective in being able to determine who is going to recur. But vein grafts over 7 centimeters are associated with occlusion.